Good morning. We have a session, Detection and Treatment of Vulnerable Plaque. With me today is Dr. Gregg from Columbia University, New York, Evelyn Regar from Rotterdam, the Netherlands, Akiko Maehara, also from Columbia, New York City. I am Jang from Mass General, Boston. All right, so why don't I show you some introduction slide. So this is what we are going to cover today. We are going to talk about definition of vulnerable plaque and how we can make a diagnosis of vulnerable plaque at the present time, and risk stratification and treatment for non-ischemic vulnerable lesions. And Dr. Stone will introduce his current study, and I will present Dr. S.J. Park's study briefly, and then we'll focus on discussion. So vulnerable plaque, the underlying mechanisms include three: plaque rupture, responsible somewhere between 55-60%, erosion 35-40%, and calcified nodule 3-8%. So there are distinct underlying mechanisms, very different. So this is a prospective study Dr. Stone carried out. So they identified three components: plaque burden, VH-TICFA, MLA less than 4. Another similar study, Remo, basically similar, plaque burden and TICFA, and VIVA. So if you combine all those three, the common definition of vulnerable plaque using the modality used in those studies are definition, the plaque burden more than 70% and TICFA, VH. Right? Everybody agrees? So, Gregg, would you like to introduce your study and the current status?
Sure. Well, we're doing a new study called Prospect 2, and it's embedded. It's also a natural history study in which we're trying to validate near-infrared spectroscopy and grayscale IVUS as a combined imaging modality for the prospective identification of vulnerable plaques, and embedded in that trial is the Prospect Absorb randomized trial. So this is a 900-patient study that we're running with our colleagues in Scandinavia, the SCAR group, actually Sweden, Denmark, and Norway. And we're taking 900 patients, acute coronary syndrome, successful PCI, very similar to what we did in Prospect. They're undergoing 3-vessel intravascular ultrasound. The IVUS is visible to the operators, but the near-infrared spectroscopy, which is performed simultaneously, is actually electronically blinded. We're actually looking to see which of those patients have a lesion by intravascular ultrasound. Actually, we've slightly changed the plaque burden criteria to 65%, but a 65% plaque burden lesion. And those lesions, which we anticipate being about 300, we're randomizing 1-to-1 to either absorb BVS with guideline-directed medical therapy or guideline-directed medical therapy alone. So that's the Prospect Absorb randomization, with the theory being that those are vulnerable plaques, at least as identified and prospectively validated on plaque burden criteria from multiple sources, if you've heard. So it's ethical to randomize those patients. We expect about a 10% 3-year event rate just on the basis of plaque burden. And our goal is to see if we can safely treat those. We expect these to be about 30% diameter stenosis lesions, so very mild angiographically appearing. And our primary endpoint is follow-up angiography and imaging at 2 years to see if we can enlarge the minimal luminal area with an acceptable complication rate. But all the patients are being followed in the SCAR registry for up to 15 years. We have a primary 2-year clinical endpoint, and the major goal of the entire Prospect 2 study is, again, to validate NIRS IVUS to see if the chemogram with a certain cutoff of lipid core burden index or max LCBI over 4 millimeters is a significant predictor along with plaque burden. And again, the whole purpose of this is then to inform a large-scale randomized trial.
So if I understood correctly, one criterion that you are using in this study is plaque burden. You're not using TICFA, you are not using others.
Well, so again, that's the criteria we're using for randomization.
Right.
We have pre-specified criteria for what a vulnerable plaque is according to either the grayscale IVUS or a lipid core burden index.
Right. And as you mentioned, plaque burden 70% corresponds to 30% diameter stenosis. Did I
Well,
understand correctly?
your plaque burden, yes, it's an area stenosis in a cross section.
yeah.
So yes.
Which correspond.
Yes.
So recent studies, including one of ours, showed the old concept, vulnerable plaque leading to acute MI, typically had diameter stenosis 30 to 70%. That may no longer be true.
Yeah.
Recent studies showed advanced tight stenosis has relatively higher prevalence of TICFA and also other features, plaque vulnerability. So with a mild degree of stenosis, whether you are really dealing with vulnerable plaque.
So I think we're confusing the concept of an angiographic diameter stenosis and, which is comparing one lumen at a lesion site to a lumen at a reference diameter, to a vulnerable plaque with a tomographic imaging technique, which is looking at a cross-section. And of course, what you get is Glygovian remodeling as atherosclerosis accommodates. So you can actually develop a lot of plaque with having a small encroachment on the lumen. So you can have a preserved lumen, but a lot of plaque. Now, we've known for a long time, actually since the early CAT study, that angiographically, the more severe any individual lesion, the more likely that individual lesion is to go on and either occlude or cause a myocardial infarction. But angiographically, most of the lesions that cause events appear relatively mild. This is a prospective randomized therapy trial in 2,000 patients. It's really an all-comers trial. Patients can have either ACS or non-ACS, in which they've gone imaging, undergone imaging with any of either grayscale IVUS, NIRS infrared spectroscopy, or OCT. And if there are 2 out of 4 criteria that are present, that's an IVUS MLA less than 4, IVUS plaque burden greater than 70%, a lipid-rich plaque on NIRS IVUS, or an OCT thin cap fibroatheroma, 2 out of the 4 present, then they can get randomized to either BVS and optimal medical therapy or optimal medical therapy alone. And the primary endpoint is at 2 years, cardiovascular death, MI, or hospitalization from unstable angina.
So one question I had was, which modality do you choose per patient?
Any of the 2.
So how do you choose?
Some sites will use OCT, some sites will use IVUS, some sites will use NIRS IVUS, so it can vary per patient, per site.
Okay, very good, thank you. So, everybody, I hope, agrees the definition of a vulnerable plaque. So those are the ones that we need to try to find, right? Plaque burden, fibrous cap thickness, necrotic core, macrophage, positive remodeling, and increased vasovasorum. Out of these 6, Akiko, what do you think is the most important component of vulnerable plaque?
I think, to be honest, fibrous cap thickness.
Fibrous
That's, I
cap
think, the most important. However, in reality or practicality, the plaque burden is most easiest way to accumulate, to pick up the most of the vulnerable plaque. Because we know the thrombotic event coming from the plaque rupture or plaque erosion, but I believe the plaque erosion is not thin cap. So if we include only the thin cap, that's not capture the erosive thrombotic event. So I think, but however, the high plaque burden is more likely causing the thrombotic event, even though the erosive thrombotic. So I think the plaque burden is more likely capture for any etiology in terms of the vulnerable plaque. But thin cap is probably most sensitive to find out. That's my opinion.
Dr. Regar?
Well, you need a certain critical amount of plaque. If you consider plaque rupture as one of the major mechanisms, then you need a certain amount of thrombogenic material being protruded into the lumen to cause significant thrombus formation or occlusive thrombus formation. So the plaque burden, of course, is a prerequisite. Then you need a thin cap, something that potentially can rupture, so thin cap, and you probably need a trigger to make it rupture. And then we have a lot of question and discussion, and the role of macrophages is postulated to weaken the cap and to make it rupture. There is also theories that intraplaque rupture of vasa vasorum can trigger rupture. So there is a lot of still questions that we need to understand. What is the trigger to make a plaque with certain morphologic features rupture?
Right. No, the reason why I ask you to pick one, maybe two, is there is no diagnostic modality which will provide information for all those 6. Dr. Stone?
I don't know which is the most important. I'm always honest. I think there's a difference between the predictors of plaque rupture or thrombosis and symptomatic plaque rupture
Exactly.
and thrombosis.
Yeah,
So
absolutely.
you can have, I think, a relatively small volume, small plaque burden, plaque, which is lipid rich and has a very thin fibrous cap, and that may be predisposed to rupture, but many of those events, maybe most, will be asymptomatic.
Absolutely.
And they'll just
For
lead
sure.
to plaque progression. I think you need a large volume of plaque to be symptomatic with some luminal encroachment.
Right.
I think it needs to be lipid rich, so a large, probably well-formed fibroatheroma. And then it needs to have a thin cap, so that's the architecture, and then it needs to have inflammatory cell infiltration with probably low endothelial shear stress, perhaps high plaque wall stress, so there's this fight between endothelial shear stress and plaque stress, and then production of matrix metalloproteinases and other collagenases that then may digest the plaque. I can't tell you which one is important. I think these imaging studies are important because they tell us, at least based on our imaging tools, which ones are most important. So far it's plaque burden, but we don't have any good OCT studies, which is the only modality that can look at fibrous cap thickness.
Absolutely right. You are making already complicated definition, even more complicated.
Sorry about that.
No, it's perfectly fine. So, obviously this is different population from what we are dealing with, right? Unless they are dead, you don't get pathology. So, according to Dr. Verman, fibrous cap is important, but necrotic core and macrophage. So let's say, according to that study, fibrous cap is important, and these are the available modalities: grayscale IVUS, VH, OCT, and IRS. So if you really were to go after fibrous cap, only modality is OCT, but OCT doesn't provide any information on plaque burden, and IVUS is the modality to get the information. So my question to all 3 of you is, Akiko already alluded, about 40% of patients with acute coronary syndrome, sudden cardiac death, underlying mechanism is plaque erosion and calcific nodule. So if you look at plaque burden, lipid, fibrous cap, you are missing this 40%. So you are basically targeting half of the patient at higher risk.
Well, we don't know. We don't know how to detect plaques that are prone to erosion.
Right.
It may be that they're, we think pathologically they're rich in proteoglycans. They may have large lipid pools. While they don't seem to have a thin fibrous cap, we don't know what they look like. Eroded plaque is a kind of a diagnosis of exclusion when you just see a thrombus with an intact fibrous cap.
Yeah.
So we need to learn more about that. I think calcific nodule is very rare. I think that's a very rare cause of vulnerable plaque.
But I think for the calcified nodule, when we look at the OCT more carefully, usually the calcified nodule occur in the very calcified cases only.
Sure. Yeah.
So if we consider that is denominator, actually, based on the patient who has any nodular calcification, how much causing the thrombotic event based on the calcified nodule, actually that hazard ratio could be not so small. That's my current feeling. We have to prove more.
Pathology studies and other OCT studies showed relatively low percentage, as Dr. Stone said. Evelyn?
But this is the beauty of invasive imaging. I mean, angiographic detection of calcium is rather rough. I mean, often we see these angiograms where we have the shadow of calcium, but you will often be surprised if you do invasive imaging that this calcium can be towards the adventitial side of the plaque, so it doesn't really hamper PCI, is probably not a risk factor. But you also have these plaques that are superficial calcium, and then if you do OCT, then you will realize that these calcific nodules, which are really protruding with a very irregular structure into the lumen. And I believe as a clinician this is fascinating to see, because somehow we always have the notion that a coronary lumen should be round. Also from IVUS with lower resolution, we often see relatively round and smooth lumen surface. And now if you do a CT, suddenly you see that lumen surface can be very rough and can really have protruding structures into the lumen.
I don't think in Prospect we didn't see a single case, right? Of
Is it
calcific nodule, not one case
It's
that
rare,
caused a
yeah.
clinical event.
Yeah, I think in overall is rare. That's
rare.
totally true. Yeah.
Roughly somewhere 3 to 5%. Yeah. So just to sum, plaque burden, you can use IVUS or even CT. CT, I think, is a good modality. And fibrous cap, OCT only. And the other important features like necrotic core, macrophage, vasovasorum, there is no real good diagnostic tool, right? Dr. Stone, are you aware of any?
You know, some people, and you're the expert to speak about this, believe that OCT can detect macrophages. I think there's a fairly high false positive rate.
Exactly.
You should speak to that, but it really hasn't been validated yet.
That's the point. Yeah. So there are a few things that have not been validated: macrophage, cholesterol crystal, microvessels, and macrophage we always add in our manuscript, but very cautious.
Yeah.
You know, has not been validated. And once we plan a study just to validate macrophage, $1 million. Okay. And the main concern that a lot of people have is a lack of natural history study. Dr. Stone, do you think that's really necessary?
I do think it's important. I think you can only learn so much from pathologic studies. We can learn approximately the nature of a vulnerable plaque, but to understand the temporal stability and which lesions at any one point of time are important to potentially act upon, you need really a prospective natural history study. So we're doing it with NIRS IVUS now. We've done it with VH IVUS, which can only go so far, and I think it's important to do with OCT.
Yeah.
I agree completely. We are really lacking understanding of the dynamic nature of coronary plaques. We are all taught in medical school that atherosclerosis is a disease that develops over decades. So we have the idea that it's a slow process. But what we start to see by systematic invasive imaging studies is that actually plaque changes are quite frequent and they can occur in a relatively short period of time, within weeks or a couple of months. So I think that is an extremely important factor that we still need to understand, because it's probably also driving the risk of the patient.
Do plaques really change over time? You know, dynamic changes so rapidly? You know, I'm aware of Dr. Min's study, Takashi
I think
Kubo.
Akiko can answer that
Could
from
you?
some of the serial VH studies.
Yeah, VH study, I mean, we need to cautious, but what we see is the baseline is if you pick up the stable patient, more less TICFA compared to the patient who suffered STEMI. And then after 1 year later, even the optimal medical therapy, they still have more TICFA. And then some TICFA change the SICAP, some change to the TICFA. So they are very dynamic. It is, we observe within 1 year. But I think what I surprised actually more is the yellow study. In the yellow study, that's using the aggressive staging therapy, and I see the years at baseline 6 weeks later, only 6 weeks. And then I see the yellow dramatically change.
Yes.
I'm very surprised. That's one big surprise.
And concern?
Any concern? Yeah, I think the reproducibility, etc., we have to consider more. But that looks real for me because we see 80 cases, and then I see side by side, and really looks different. That looks like the true. So that's a big surprise. And also in the Horizon study, compared to the baseline follow-up, we see the calcium not exist in the baseline attenuated plaque, but attenuated plaque change to the calcium. at 1 year. So I was so surprised. Calcium can develop within 1 year. So that's our observation based on the imaging serial study. So I think to understand those things is very important.
So,
Yes.
Dr. Sun, how is it possible the
Yeah.
lipid in the vessel wall reverse transferred
Yeah. Well, you know,
in 6 weeks?
we've certainly seen some of those studies that I think are very convincing with drugs like ApoA1 Milano, which we've seen animal studies where you can just suck the lipid out of the wall. But this, of course, is not with ApoA1 Milano. I have questions about all of this as well. I think, you know, the reproducibility of VH from one study to another is got some questions. The yellow study, there were differences in the lipid values at baseline, so there might have been a regression to the mean phenomenon. So I think we need more data. I think the most convincing concept is from the VH studies is that in stable CAD, there seemed to be a fair amount of changing morphology, where in STEMI patients, in Horizons where we had serial and 13-month follow-up, there was a drive towards more vulnerability. So you didn't get thick caps develop, you didn't get lipids regressed. It seemed like those patients who we know have ongoing inflammation stayed unstable, whereas patients with stable coronary disease, the morphologies were a little bit more variable. But we need a lot more insight into the temporal changes.
Despite contemporary medical therapy with high intensity.
Exactly.
That's important. Dr. Regar, comments on that?
Yeah, I think
Natural
I
history.
agree. We need certainly a better and more thorough validation of our tools. But the good news is that we have, as cardiologists, the tools in our hands now, and we can really go into this endeavor.
Yeah. Okay. And then how to treat this? You know, Dr. Stone mentioned the importance of a natural history study, but at the same time, you introduced this smart design treat. So local versus, I prepared this. So this is with contemporary medical therapy. So 3 time point IVUS. I'm sure Akiko knows this. And then baseline OCT. So the left upper is 70% of people with contemporary medical therapy. Plaque does not grow. Percent atheroma volume, actually it regresses. It's a 70%. And then right upper, slow progression despite medical therapy. And then lower 2 panels, either early or late, rapid progression, phasing. So those are the ones that we are concerned. You know, regression is a good thing. Slow progression, when they come to the threshold, they will develop exertional angina. We stent it. End of the story. But rapid phasing, those patterns are the ones that will cause acute MI, sudden death. And we look at fibrous cap thickness. You know, after 6 months of statin therapy, fibrous cap thickness doubles. And after 12-month therapy, it triples. So if fibrous cap thickness, the thinnest portion is 170, 180, will that really rupture? And prevalence of TICFA, especially with intensive statin therapy, from 64% to 17% after 6 months. This is not zero, so that probably should be the target population for local therapy. So my question, last question, is timing of prospective study. We all agree we have to test this with first generation BVS. There's nobody else who can answer this question better than you, Gregg. You know, there are some issues, some problems, including stent thrombosis. Is this the right time to test your hypothesis, or should you have waited a bit longer for better stent?
So, first of all, let me address some of the regression issues, I think, which are very important. I think it partly depends on the patient population you're studying. And I'm not sure which study, patient population that first study was from with the rapid lesion progression, about 30% of the patients or so. We find that in patients with acute coronary syndromes who have ongoing systemic inflammation, which is a driver to progression, that they are more likely to progress. So I think that stable coronary disease patients are less likely to have untreated thin cap fibroatheromas, and I do think they progress much slower. I think the ACS patient is very different. And even with high-dose statins, those patients are still having events, as we saw in Prospect, as you see in the Timmy Prove-It study. High-dose statins, which I do believe will thicken the fibrous cap, on a population basis, will improve overall outcomes, but there are still a substantial proportion of patients having events. So I do think that bioresorbable scaffolds may be ideally suited for this type of lesion. You know, again, angiographic leads appear very mild. The lumens tend to be larger than in tight stenoses. The plaques tend to be softer, so the BVS can expand easy, and the thicker strut is not a major issue because, again, the lumens are larger. We know that metallic drug-eluting stents heal relatively poorly when you implant them in thin cap fibroatheromas. We have some early data from the randomized Trophy 2 trial, to suggest that in STEMI at least, BVS may heal, if not as good, then better than metallic cobalt chromium everolimus-eluting stents. And so I think it's a reasonable hypothesis, and you have to start sometime.
Yes.
We're starting cautiously with only 300 patients with high plaque burden, who we know those patients, despite optimal medical therapy, are going to have about a 10% 3-year event rate. The BVS thrombosis rate we've presented at this meeting and others seems to be primarily limited to very small vessels. These are not very small vessels for the most part. These are proximal and mid-coronary tree, 3 millimeter and larger vessels. So I think it will be safe therapy, but that's why we're cautiously looking to see what's the likelihood of periprocedural myonecrosis from rupturing a thin fibrous cap, and what will be the restenosis and thrombosis rates.
Dr. Regar? The timing, I agree that at some point you are going to have to start, right? You cannot just keep waiting.
Right.
Is this the right time?
You know, it's not a bad time, because don't forget, BVS is in clinical trials since 2006, 2005. So there is a body of research being done. We understand the pitfalls and limitations of this technology quite well, especially when it comes to all the ins and outs of implantation technique. So I think it's not a bad time. And we also see, we should not forget, we see the long-term follow-up in these patients. It's really compelling. I mean, this is a therapy that, at least in the majority of the patients, shows lumen enlargement with plaque reduction in plaque burden in most of the patient. It shows restoration of vasomotion, and it shows the development of a new layer on the endoluminal side, which is called recapping the cap or neomedia, we don't know exactly. And also this layer is at least hypothesized to be beneficial in the future. So there is risk, but there's also a number of potential benefits. And from that point of view, I think it's a good time.
And Dr. Maehara, you look at a lot of images, vascular response to BVS, and you are convinced that BVS will take care of all these vulnerable plaques?
Yeah. Yeah, based on what I think, the Prospect 2 trial, and they are putting the small, not small vessel, large proximal vessel, and they are putting the all bulky vulnerable plaque. So visually, I feel they are sealing by BVS without too much complication.
So last question is, we practice medicine in different era these days. Cost is so much important. I have almost zero knowledge in cost effectiveness, but we get pressure all the time. Your vision, when patient comes in with the ACS, 3-vessel imaging, you see vulnerable plaque, BVS, is that the future?
It's a great question. At a minimum, all these patients are going to be on intense systemic therapy. The PCSK9 inhibitors have the potential to be a game changer, but when you talk about cost effective, right now at $14,000 a year in the United States, they're considered not cost effective. perhaps if we used imaging to find an enriched population where the event rates are much higher, then they could be cost effective. The medicines company is developing an mRNA inhibitor that you might give twice a year instead of once a month, and that might be very cost effective. So I think the vision is going to be based on what the systemic therapy landscape looks like, and there's other anti-inflammatory agents that Paul Ridker and others are developing. That being said, we also don't know, is there some way that we can get some sense as to where we might image? Can we image 20% stenoses as opposed to the entire coronary tree? Can we limit it to just the proximal half of the coronary vessels? Is the circumflex less important? I think it's a little hard right now for me to predict what a vision will look like. But if this is very successful, assuming that statins and dual antiplatelet therapy remain the standard therapies without much more potent types of agents, it's not inconceivable that in patients who already present with acute coronary syndromes that we will be looking for and treating vulnerable plaques. Much more difficult, and the holy grail is population screening type studies to look at high-risk patients, to use CT angiography, and then to really try to prevent death and myocardial infarction, the first event. That's very exciting, but I think the event rates are so low still relatively, it's much more difficult.
And European perspective?
Well, I don't know the European perspective for the cost effectiveness, but if I put myself in the shoes of the patient who comes in the middle of the night with an acute myocardial infarction into a cath lab, what I would love to hear from my doctor is that he says, you have a problem, I took care of the problem, and by the way, I scanned the rest of your arteries, and we found 2 spots, and we can treat them now, or we found 2 other spots that are at risk, and we will treat them in 3 days. So what I would love as a patient is complete diagnosis, risk assessment, and treatment plan. And I want to leave the hospital as quickly as possible. What is happening in Europe is most people consider treating the culprit lesion in acute myocardial infarction. Then the patient is allowed to recover. He is dismissed. Then we do a stress test, and if there is residual ischemia, the patient is brought back to the cath lab. So it's a lengthy process. The patient has to go a number of non-invasive testing, and then comes back to the cath lab. So from a patient perspective, this is not what patients like. It also involves a lot of resources. So I guess we will have possibilities in the future to do better.
And those tests don't detect that non-invasive stress tests aren't detecting vulnerable plaques, right?
They are not detecting vulnerable plaque, and we have high number of false positive, false negative, so patients end up with a stress test, another stress test, cath lab, and so on. So I think we really have a lot of headroom to become better. And whether the therapy is local or whether it's advanced drug or whatever, that is yet to be seen.
So one practical question before I ask Dr. Maehara. So you fix the culprit lesion and you see in another vessel maybe 50, maybe 70. Would you do FFR or imaging?
Today or in the future?
5 years from now.
5 years from now? I think that it's a very interesting discussion as to why FFR positive lesions may be associated with death and MI. Why should ischemia-related lesions, why should ischemia cause death and myocardial infarction? No one is suggesting it's because you're getting sudden death from arrhythmias from that. I think it's more likely because it's associated with vulnerable plaques.
Right.
The more FFR positive, more likely to have large plaque burden, it's endothelial dysfunction, there's other links that we are finding. So I think that in those patients, imaging is actually more important than FFR. If you're looking for severe lesions to prevent angina, to treat angina, that you can do anytime.
Right.
That's less critical. But especially in the patient that comes in with an AMI, again, with high levels of inflammation, who may have multiple ruptured plaques already that you may not be able to appreciate and be prone to that within the next month or 6 months, I think imaging will be more important.
You know, last 2014, we published in JAG, those severely stenotic lesions have much higher prevalence of TICFA and also other features of vulnerability.
Yeah.
So not just exertional
Right.
angina, but they may develop
Right.
ACS. Dr. Maehara, the last thought, your vision?
In terms of the cost effectiveness, I don't think the BBS is compared to the optimal medical therapy and current invasive technique can better. I don't think can better in terms of the cost effectiveness. But my vision for the vulnerable plaque is really to find out who is going to die tomorrow without any therapy. I really want to reach to treat the patient who suddenly die, who never have the coronary event in the past. So based on our understanding, we really have to go to the primary prevention. That's really my goal, and we have to look for. That's, yeah.
All right, with that, we will wrap this up. Thank you very much. I think we're on time.
Great.
Thank
Thank
you.
you.
Thank you very much.